Ishrat Jahan Shimu for her presentation regarding anaconda in the heart, what to do. Dr. Ishrat Jahan Shimu, please.
Thank you, IPTI, for giving me the opportunity to present my case. I am Dr. Ishrat Jahan Shimu from NICVD, and title of my study case is Anaconda in the Heart, What to Do. And my case is a 17 years male who presented with fever for 18 days and effort intolerance since childhood, and on general examination, he was mildly anemic with temperature 103 degree Fahrenheit with no lymphadenopathy or organomegaly, and other examination findings was normal, but precordial examination has the apex is shifted to the left 6 intercostal space with a continuous murmur of grade 3 by 6 along the parasternal border of second and third intercostal space. And his investigation report shows then hemoglobin, which is initially normal, but with time it reduces up to 7 gram per dl, and ESR was mildly raised with 43 millimeter, and total count of WBC was increased initially, and with time it reduces as he received several antibiotics. But creatinine level was progressively rising from 1.4 milligram per dl to up to 4 milligram per dl, and CRP was raised with 66 milligram per dl. And blood culture, which was done outside the Dhaka city, revealed growth of Staphylococcus species, but in Dhaka city we did again blood culture which shows no growth, and urinary initially was normal, but with time there was significant albuminuria with presence of plenty pus cell, RBC, granular cast, and also 24-hour urinary total protein was 11.2 gram. ECG was normal, and his echocardiography shows in parasternal long axis view, the LV was mildly dilated, but in short axis view, there is a tunnel-like chamber within the right atrium, and the MOD echocardiography shows that this LV function is normal. And this is the moving clip from the parasternal short axis view, which shows a tunnel-like structures which arises from the right coronary sinus of the aorta and winds round and with a sinusoidal course and ends into the right atrium with a left to right shunt. And this is another moving picture which shows there is a moving structure attached to the interatrial septum, like which is the vegetation, and another side, the still picture shows the vegetation. It's attached to the interatrial septum. And this is the gradient which shows the left to right shunt had a peak gradient of 94 millimeter of mercury. And this is apical 4-chamber view, which shows that is left atrium is normal, but right atrium, there is a tunnel-like structure ends near the right atrial roof in front and with the left to right shunt. And so the final echocardiographic report was aorticocameral fistula with a tunnel-like fistula originate from the right sinus, which ultimately drains into the roof of the right atrial cavity. And fistula and tunnel have a sinuous course with continuous left to right shunt with PPG 94 millimeter of mercury, with dilated right atrium and right ventricle, and with good biventricular function. His CT angiogram shows that is LAD is directly arises from the left coronary sinus, and LCX is arises from the proximal dilated part of the RCA, and the RCA is arises from the right coronary sinus normally, but it is dilated and has a sinuous course and ends into the right atrium with a proximal diameter of 28 millimeter and distal diameter of 16 millimeter. And this is the sagittal section, and on the left side, it shows that the LAD is directly arises from the left coronary sinus instead of left main coronary artery. And these are the final results of CT coronary angiogram, which I already mentioned. And this is an overview for the coronary cameral fistula. It is a rare abnormal communication between a coronary artery and the cardiac chamber, and it is present only in less than 1% of population and in less than in 0.1% to 0.2% coronary angiographic studies. And the most common cause of coronary cameral fistula are abnormal embryogenesis, but there are some acquired cause also. And usually the small fistula remains silent and patient may remain asymptomatic. But in case of large fistula, it can cause significant complications like congestive heart failure, myocardial ischemia, infectious endocarditis, even sudden cardiac death. And there are some diagnostic tools for diagnosing the coronary cameral fistula. Most important is the transthoracic echocardiography, which is a very useful tool for diagnosing the origin, exit, and also the pathway, and most prominently delineated in the color flow mapping. Transesophageal echo is another sensitive tool, and also it is a complementary tool for deploying the device to guide the device deployment. And the cardiac catheterization is the gold standard for complete anatomic and hemodynamic characterization. Cardiac CT is another procedure, and others are 3D CT image and CMR. Management is according to the SSC-AHA guidelines. It recommended the closure of fistula regardless of the symptoms, either transcatheter device closure or surgical ligation. And this is the take-home message for me. That is, coronary artery fistula, although it is a very rare complications, infective endocarditis may complicate the dilated coronary cameral fistula and with unilateral fistula draining into the right heart. And due to potential severity of complications, SSC-AHA recommend closure of the shunt regardless of the symptoms, but some authors still differ and advocate intervention only in presence of symptoms or complications. That's all for my case, and thank you all for patient sharing.
Thank you, Dr. Shimu, for your beautiful presentation.